Hello, and welcome to the second last Radiopedia Friday live stream. We are now in the final weeks in the run-up to Radiopedia 2022, which will be running from the 25th to the 29th of July. Registration is still open and it's free if you are registering from one of 125 low and middle income countries that are listed on our website, or if you hold a Radiopedia All Access Pass. We have also tiered and concession pricing available, and all the details will be at radiopedia.org. This year, we are again very excited to be bringing you some excellent content from some of the world's best medical imaging educators, with over 70 brand new lectures debuting over the course of the 5-day conference. For this week's live stream, I'm proud to introduce Dai Roberts, who will be encoring his presentation and approach to shoulder MRI. I know I find this tricky, and I think this is an excellent presentation to help with some of those nuances of interpretation of shoulder imaging. Welcome, Dai, and I'll see you at the end.
Hi, I'm Dai Roberts. I'm a consultant based in Belfast, and over the next 35 minutes or so, we're going to be talking about an approach to shoulder MRI. These are the things we're going to cover today. We're going to be talking about imaging planes and how best to assess the adequacy of the sequences obtained. We'll be talking about the protocols and why we use them and when best to use them. And then we're really going to focus on those three main things: the glenoid and labrum, the capsule, and the rotator cuff. Now, before you ask, no, that is not me before lockdown. That is my younger brother, Chris. He's there to remind us all the most important thing when it comes to musculoskeletal MRI, and that is knowing your anatomy. Everyone has muscle like Chris's in some shape or form, and knowing that and their names along with the other structures of the joints really helps us understand normal from abnormal, and also then we can also describe our areas of abnormality in a way people can understand in our reports. There's a set number of imaging planes which we use, and that's our axial, coronal oblique and our sagittal oblique sequences when it comes to shoulder MRI. Hopefully everyone's used to the axials, same as our other axial planes and other joints. And then the coronal oblique and the sagittal oblique are essentially sequences which are slightly off, not on the pure coronal or sagittal, and we'll touch on how we create those sequences and how we should assess their adequacy. To start with the axials, I've labelled a couple of the important structures on the next couple of slides, and then in the smaller box you'll be able to see the reference point on a different orientation with this yellow dotted line. The first thing I tend to do is to see whether or not the patient has been scanned in external rotation. And we do that by looking at the proximal long head of biceps within the bicipital groove, which is labelled here, and we can see that nice dot low signal structure there. And this tells us that the patient has been scanned in this external rotation position. So this is a right shoulder, so you want to be seeing if it's a 10 o'clock position and the opposite for the other side. And we really want to do that to ensure we're looking appropriately at these anterior structures. Now, if the shoulder is scanned in neutral or slight internal rotation, you get redundancy of these and they all become very wavy. So the subscapularis, the anterior labrum, the anterior capsule become a lot more difficult to appreciate. So we really have to ensure that we're scanning these patients properly. On this view, you can also see the glenohumeral joint and the articular cartilage of the humerus here. And then this is the glenoid. As we come inferiorly, it's important to really appreciate what a normal glenoid looks like. Most of these dislocation cases we're going to be asking about bony Bancarts, and a normal glenoid has this triangular appearance as we come inferiorly. Okay, so on all of our shoulders, really get a little image bank of what a normal glenoid looks like, and again, if you know your anatomy, it'll really help you understand what abnormal looks like. Nice sharp contours, and there's no previous or current bony Bancart. Again, we see the proximal long head of biceps tendon, bit of subscap, and there's probably a little bit of infraspinatus here. Superiorly, we come to the second most important tendon in the shoulder for me, and that's the supraspinatus tendon. In axials, you will see that you've got this nice black line here, and it goes into the muscle, and that is the supraspinatus tendon muscle itself, tendon itself, and here's the muscle. Now this is a really important structure because that's how we align our coronal oblique sequences. So if a well lined up coronal oblique sequence, you should see it a reference point line perfectly parallel to that supraspinatus tendon. And we want to do that to really best assess for tendinosis and partial thickness tearing. And if the plane is slightly off what we want, more oblique or less oblique, it really makes assessment of tendinosis and tears much more difficult. As annotated, this is the supraspinatus tendon. We've got the subacromial subdeltoid bursa over the top, the acromion, AC joint, glenohumeral joint. Then this is my best view for looking at the axillary pouch. The sagittal oblique sequence should be perpendicular to the coronal oblique sequence, okay? And we do that to assess the cuff, the glenoid, and the rotator cuff muscles. Coming back to the most important tendon in the shoulder, that proximal long head of biceps tendon. It really helps us orientate ourselves in terms of what's next to it and what's anterior. So we know that this is the superior and lateral aspect of the subscapularis tendon. Here must be the leading edge or the anterior aspect of supraspinatus, and that leads into infraspinatus, and teres minor is there. Now, if you've got a complete tear of the proximal long head of biceps, it's a bit more difficult, but again, really look for that, and it'll really help you orientate yourself. As we scroll more medially, we're looking at the glenoid, and again, that's why we want this really well aligned sagittal oblique sequence in order to get this nice round view of the glenoid. The coracoid process is a really important structure, in my opinion, in the shoulder also, because we know that this is anterior. Therefore, if we see that this structure is to the left, we know that the anterior glenoid is here, and vice versa. If the scan is uploaded in a different way, that bony prominence is going to be a constant. So that'll help us decide what's anterior and what's posterior, and we can see some of the rotator cuff muscles coming into plane here, such as the supraspinatus, the subscapularis with its multi-pennate appearance. We've got infra, and then teres minor. As we scroll more towards the chest, medially, we will see the larger bulk of the muscles, and we've got the supraspinatus muscle up here in the suprascapular fossa. We've got the infraspinatus muscle here, subscap, and they all look normal, good, healthy muscles. In terms of protocols, there's two main sorts. Most people should be having a routine or non-arthrographic shoulder MRI, and that should be able to assess most things as listed there. Arthrograms are specialist studies, and we should only do those in people who were worried about the labrum or the glenoid, and if they've had any traumatic capsular injuries. And the main group are going to be our dislocators, whether anterior or posterior. Those are the ones we're going to want to do that. And we're not going to want to do arthrograms in older populations, such as 50 to 60-year-olds, because they're going to have labral tears, and we only want to do an investigation if it's really going to change the management of the patient. Slap injuries and other things which arthrograms are going to be a bit more sensitive for compared to the routine MRI. And I've put a rotator cuff star there. If people have had rotator cuff repair, arthrograms are going to be a bit more sensitive at assessing for full thickness tears which are not fully retracted. But again, that's a bit more of a specialist request. You probably appreciate that the non-arthrographic and the arthrographic studies are going to be performed slightly differently, and the arthrograms are going to be heavily T1 fat saturated sequences. And the reason we do that is because there's only so many things which are high signal on T1 weighted imaging. And it was always taught to me the best way to remember this is BFG, blood, fat, and GAD. There's certain blood products which will be high signal on T1 weighted sequences, like hemarthrosis on someone who's anteriorly dislocated their shoulder. So certain blood products. Hopefully we know that fat is bright on T1, so you can see the fatty marrow within the humerus here, and also the high signal of the subcutaneous fat. And on this sequence, we've got our T1 fat saturated sequence, so we've nullified the fat signal and we're only left with the gadolinium. Most will know that we have high signal fluid on T2 weighted sequences, whereas on T1 weighted sequences, fluid will be low signal. So on our T1 fat saturated sequences, we're assessing the pure gadolinium solution, and you can see areas of labral tearing like this, and we know that it increases the sensitivity of our assessment. Now, understanding the pathophysiology of dislocators really helps us understand how to interpret these studies. This is a right shoulder axial view, which is annotated as so. The humeral head sits centrally within the glenoid, and then we have the anterior and posterior labrum. When someone anteriorly dislocates, they're going to either injure the anterior labrum or the anterior labrum and the anterior glenoid. So that could be a soft tissue Bankart or a variant of, and that could be a bony Bankart. Now, we don't tend to MRI people who have dislocated and are currently dislocated. They won't stay still, and it won't really help us. Sometimes people, if they have an engaging Hill-Sachs or something similar, they will be CT'd in that position, but we don't tend to do it in MRI. So we're going to see people who are relocated after that traumatic injury. And what we're looking for is this posterior and lateral impaction fracture in the humeral head, which we call a Hill-Sachs defect. Now, if you see one of those, you should have a really good look at the anterior stabilizing structures, both the labrum and the glenoid, because we know that they've definitely dislocated. You will have many requests of people who have subluxed or query dislocation, but if someone's got a Hill-Sachs defect, most likely they've anteriorly dislocated, and we have to have a good look at the front. Now, if people have posteriorly dislocated, they're going to have the reverse. So you're going to have a anterior medial impaction fracture of the humeral head, which is the reverse of a Hill-Sachs defect and called a reverse Hill-Sachs defect. And if you see a reverse Hill-Sachs defect, we're doing the opposite. We're having a really good look at the posterior labrum and posterior glenoid to look for those reverse Bankarts or reverse bony Bankarts. How do we assess for a Hill-Sachs defect? Well, I like doing it on the axial sequences. We start at the supraspinatus tendon above the humeral head, and as we scroll, we see the humeral head, we count 1, 2, 3 slices, and it's usually at a similar level to the coracoid process, and you will see here an impaction fracture. So this person's got quite a big Hill-Sachs defect. We should be putting best fit circles on these axial sequences because the humeral head, again, should be really nice and round. And if we have a look at people who have not dislocated, you will come to appreciate the normal appearance of that. I like measuring both the length of the Hill-Sachs defect for those on-track lesions, which you can read more about. And I also like mentioning the depth because I think that makes a little bit of difference. Assessing the labrum is important in dislocators because the surgeons want to know what sort of injury they've had, whether or not it involves the articular cartilage, whether or not they can repair it, or they can just fix the normal anatomy back down. So we have to understand again what normal is. The anterior labrum obviously sits next to the anterior glenoid here. We've got the articular cartilage, and then we've got the capsule. And most of these glenohumeral ligaments are essentially thickening of the capsule themselves, and then we've got the attachment, which is the periosteum. Now, all of these areas describe injuries to the labrum in the anterior inferior or 3 o'clock to 6 o'clock position. Okay, so you've got complete detachment of both the labrum and the capsule. On the soft tissue Bankarts, we've just intact capsule with the Perthes lesion with detachment of the labrum. If you've got an articular cartilage injury, it's going to be a GLAD lesion, so that's glenolabral articular disruption. So they're fairly descriptive, and an ALPSA, as it states, was essentially periosteal avulsion injury. Something we have to be careful of is normal variants, and particularly that 12 o'clock to 3 o'clock position, you can get them. So that would be the anterior superior aspect. So you could either have a recess, which is this smooth contour beneath the labrum, or you could have a sublabral foramen, which is a complete smooth contour beneath it. It was always taught to me that if someone doesn't have a Hill-Sachs defect, and all they've got is these changes within the 12 o'clock to 3 o'clock position, be really careful about calling these as tears, because most often they're not. So we're really looking at that 3 o'clock to 6 o'clock position, that anterior inferior labrum, and these are the areas in the anterior superior labrum where you can get a anatomical variance. We've talked a little bit about the clock face there, and occasionally it can confuse people, and we need to make sure that we're conveying our findings well to the surgeons so they understand exactly what we're saying. The confusion does come because of the reverse positions of both the sagittal oblique sequence and the clock faces. Hopefully we can all appreciate that there are two shoulders, left and right. We've got our normal position of our clock faces, and again we're using our bony process here of the coronoid process, and that is an anterior structure. So on the right we've got the 3 o'clock position, which is the anterior glenoid. Now if the sagittal oblique sequences are uploaded as shown, we can see that the anterior is actually going to be the 9 o'clock position and 3 o'clock is posterior. We don't want to confuse people by talking about anterior inferior labral tears from 3 o'clock to 6 o'clock if the clock face we're using is conventional. Okay, for me, I always like having 3 o'clock anterior, and we need to make sure that we're using this in our reports in order to convey our findings. So again, anterior process of the coracoid, 3 o'clock, and we reverse the clock face if the study is uploaded like this. In your institutions, you may find that the sagittal oblique sequences are uploaded in a number of different ways, but if we're using our bony prominences and our coracoid process, hopefully it'll really help us eliminate any confusion. It was taught to me that we should ensure the person reading our reports understands what we state as 3 o'clock. Say if there was an injury of the anterior inferior labrum here, and we know that, again, because we've got our bony process, coracoid there, you could either do one of two things. You could either say chondrolabral separation from 3 o'clock to 6 o'clock, and then in brackets say 3 o'clock anterior. And I think that's really useful, nice and clear. Alternatively, you could talk about anatomical quadrants and say chondrolabral separation of the anterior inferior labrum from 3 o'clock to 6 o'clock, or a combination of both. Okay, but we need to make sure that we're consistent. Our 3 o'clock position should always be consistent. For me, I really like it as anterior labrum, and we need to convey that in our reports. Slap lesions, so the superior labrum anterior to posterior tear. So the bicipital labral complex is essentially where the proximal long head of biceps origin is at the superior aspect of the glenoid. On the left, you can see a normal insertion where there isn't any gadolinium extending into there, whereas on this study, you can see that there is a slap tear. You can see gadolinium extending up here, and you've also got an associated tear which extends into the long head of biceps tendon itself. Now there's many different classifications of these. It's probably good to have an awareness, but again, I wouldn't just use that classification. I'd make sure you describe your findings well to ensure everyone understands what you mean. As well as looking on these dislocating cases at the labrum, we need to ensure we're assessing the bony structures, in particular the glenoid, and to say whether or not someone's got a bony Bankart or a reverse bony Bankart. So this person has anteriorly dislocated, and they've been out quite a few times. So we've got the glenoid here. This is our left shoulder, so this is anterior. And as we scroll down, you can see that you've lost this normal triangular shape. It's got a fairly sclerotic border, so we know that it's not an acute finding. So this person has got a fairly large and chronic bony Bankart. On our sagittal oblique sequence, you can see it even better. And again, we're using our coracoid process, so that's anterior, so we know that this is the anterior inferior aspect of the glenoid. On MRI, it can be sometimes a little bit more difficult to look at our bony Bankarts, but again, we should be assessing this. So this is left shoulder, this is anterior. As we scroll down, you can see that it's losing its normal triangular shape. And on our sagittal oblique sequence, you can see here that this is our anterior glenoid defect, so a bony Bankart. I think we should be classifying this in terms of percentage glenoid loss. We should be putting a best fit circle on this sagittal oblique sequence on what we think the anatomically normal glenoid measures the diameter, which in this case I've taken as 28 millimeters, measure the size of the defect, which is 5 millimeters, and then altogether coming with an 18% glenoid bone loss in this particular case. And I try and do this routinely, and again this also helps with measuring those on-track and on-track lesions. Capsular injuries can occur, and it's surprising how frequently they occur with people who anteriorly dislocate. What we're looking at on these coronal oblique sequences is a nice, almost teardrop shape to the axillary pouch. Nice, smooth and crisp. There are different attachments of the anterior or the inferior glenohumeral ligaments. The I is sort of dropped from the acronym, and it can either come off on the humeral side, making a haggle, and you can usually see contrast extending down the humeral shaft, whereas with a gaggle or a glenoid avulsion of the inferior glenohumeral ligaments, you usually see contrast extending on the inferior aspect of the scapula here. There's a couple of special mentions. There's a couple of special mentions when it comes to arthrogram studies and the labrum. We should be wary of overcalling these Buford complexes, which is where there's a congenitally absent labrum from 1 o'clock to 3 o'clock, the anterior superior position, where you have a thickened middle glenohumeral ligament, and this can sometimes confuse people, and it can be called an intra-articular body or a labral tear with displacement. And on this non-arthrogram, it can be a little bit tricky to see, but again, it's really useful to ensure that we're assessing these properly, and if there is confusion, we should go on for an arthrogram. The surgeons like knowing about these os acromiali. Occasionally they can cause symptoms, and it's essentially a unfused apophysis of the acromion, and on this 2-1 axial sequence you can see a line up here with the acromion. This is the acromoclavicular joint, and this is the clavicle. Now hopefully we don't see this too often, but this is the black contrast effect, and this is a really nice case. It comes up quite frequently in conferences and exams, and if we give a over-concentrated strength of gadolinium, it loses its T1 properties, and we end up getting the opposite. We get a T1 signal dropout, and you get a black contrast effect. Okay, so that's a nice case to know about. Let's look at a case in total. Okay, so we've got an axial T1 fat saturated sequence, and then we've got the gadolinium here. So if we were to scroll up to the top, so now you can see the supraspinatus tendon here. If we were to scroll, we see the humeral head 1, 2, 3. You'll have to believe me a little bit that there's a tiny little Hill-Sachs defect there. It's not perfectly round. So again, we want to have a really good look at that anterior inferior labrum. This is the area we should be looking at. As we scroll down, you can see that there's detachment of here, and it doesn't look attached to the actual periosteum here. So this is a soft tissue Bankart for me. As we scroll superiorly to see whether or not there's other labral tears, you can see that there's a little fluid cleft in the region of the proximal long head of biceps insertion, and this sometimes can be better seen on these coronal oblique sequence. Similar to the case before, you can see a slap tear with a tear extending into the proximal long head of biceps tendon insertion. Like we mentioned, we should be looking at the capsule as well. Nice teardrop shape there. And as we scroll backwards, you can see that there's a lot of fraying from the humeral insertion of that posterior band of that IGHL. So this is a posterior band haggle. The rotator cuff tendons are best assessed on our routine or non-arthrographic study, because we want to be using our fluid sensitive sequences such as our STIRS or PD FATSAT sequences, as opposed to our T1 FATSAT sequences on the arthrograms. Here's an image we saw before, and again, this proximal long head of biceps for me is the important one, and it really helps us orientate ourselves. And as labelled, you can see the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. In both arthrograms and non-arthrographic sequences, I like looking at the proximal long head of biceps tendon first, because it can be an important area, and it can be a pain generator. So it should sit quite nicely within the bicipital groove here, nice low signal structure. It can dislocate, so it looks a little bit flattened, and it's going into this superior lateral aspect of the subscapularis. So medial dislocation there, and with a complete tear it'll be absent. And sometimes these can be a little bit difficult to pick up compared to ultrasound, where you can see if someone's got that Popeye sign, whereas MR, it tends to be focused all around the shoulder itself, and you won't actually catch that retracted muscle belly into the arm. When we're assessing the rotator cuff and tendon tears, we need to be talking about whether or not it's complete, partial thickness, and if it is partial thickness, whether or not it occurs on the bursal surface or articular surface. So we have the subacromial subdeltoid bursa, which runs over the top of the rotator cuff tendons, and it's probably best appreciated on the coronal oblique sequence here. Therefore, this is the bursal surface. We have the articular surface here, which is adjacent to the humeral head articular surface, hence the articular surface. And the enthesis is that insertion of that tendon. Generally, normal tendons don't tear, and unless there's really high velocity trauma, most people who have rotator cuff tears tend to have a degree of tendinopathy. A normal tendon should be a nice low signal structure, and in our institution we like using our stir sequences because it prevents any magic angle artifact within this sort of critical zone here with our longer T2 sequences. It helps a little bit. In this person you can both see subtle thickening of the tendon, and obviously it's a high signal, so this is in keeping with fairly good going tendinopathy. And calcification is another thing we should be assessing for. It can be quite hard if there's little areas of small foci of calcification on MRI, and it can be more difficult to pick up than say ultrasound or plain film, and we should be comparing both all together. The subacromial subdeltoid bursa is also an important structure to look at because it can be another pain generator. The normal subacromial subdeltoid bursa should be a nice thin fluid filled line which just extends over the top of the supraspinatus and the other rotator cuff tendons, and it's actually quite large. It extends usually all the way down here, as you can see on this area on the right. For me, I like trying to differentiate between a distended bursa and a bursitis. Now you have to take my word for it that this person has got a full thickness rotator cuff tear, and that means that you've got free communication with the glenohumeral joint into the subacromial bursa. Now you don't have any inflammatory fat stranding, edema, or really a sort of angry appearance here, and I think it just is just joint fluid. Now I see some people describe this as a bursitis, but for me it's not technically true. I think for a bursitis you really want to see an angry, inflamed bursa, and usually it looks a little bit irregular and you see associated changes. So I think we can describe the bursa as being distended, but I think in terms of our certainty about whether or not that's a bursitis or not, that's something to really think about. Something I think MRI really is superior to ultrasound is the assessment of the rotator cuff tendons and the degree of fatty replacement and atrophy. There's a classification, Gautelier's, which is from grade 0, which is normal, all the way to grade 4, which is over 50% fatty degeneration. We should look at the tendons and muscles and state whether or not there is fatty replacement and how much atrophy there is. And for me, we should be describing it as opposed to just saying grade 2 changes, because not everyone will understand this classification. If we look at a case, so we've got a really well aligned sagittal oblique sequence, and then we've got the anterior structure here, which is the coracoid. So this is the subscapularis, this is the supraspinatus, the infraspinatus here, and you've got the muscle, and then you've got the tendons starting to form here, this low signal structure. Now as we scroll laterally, you can see that the supraspinatus tendon is going to get more prominent. Again, this is where the cuff forms, and as we scroll forward, forward, here's a little fluid-filled cleft just by here, and it doesn't look like it's a full thickness tear. You've still got some tendon over the top. So for me, these sagittal oblique sequences, what I find most useful, and I do a bit of problem solving on our coronal oblique sequences, and you can see quite nicely here that you have a partial thickness bursal surface tear, which is at the enthesis with intrasubstance extension. We know it's not a full thickness tear because you still have articular surface fibers intact at the back. If we look at another case, so we have a sagittal oblique sequence and we're looking at the supraspinatus. We've got the supraspinatus muscle and the supraspinatus tendon. We know that this is anterior because we've got the coracoid process here. So as we scroll forward, long head of biceps tendon, and here we have a large fluid gap. So this is a full thickness tear. You can't convincingly see any normal tendon, and that cuff is disrupted. This can be confirmed on our coronal oblique sequence, where you can see that that anterior aspect of the supraspinatus tendon has torn and retracted. And as we scroll back, you can see that it extends into the critical zone, which is usually 1.5 centimeters from the insertion. And then you have a partial thickness articular surface tear there with associated tendinosis. If we were to look at the muscles, supraspinatus, subscapularis and infraspinatus, and there isn't any fatty replacement there. We should assess the glenohumeral joint and whether or not there's an effusion or if there's any other changes when we're looking on our shoulder MRI. A normal won't have an effusion. You can have a little bit of fluid, but that's normal. And again, it's just understanding how much of fluid is normal. A top tip would be not to talk about effusions with our arthrograms, because we've given someone fluid into the joint. You could talk about whether or not there's adequate distension, but don't talk about effusions with your arthrograms. In this person's recently dislocated and they have a large effusion. If we have a look at the anterior glenoid here, you can see that this person's got a bony Bankart. So this is an indirect arthrogram. We haven't done an injection, and we know that because this fluid here is not high signal on this T1 weighted sequence, so therefore it cannot be gadolinium. Another thing which seems to be quite a common occurrence, which is something which can be picked up on shoulder MRI, is frozen shoulder or adhesive capsulitis. What we're looking at there is this axillary pouch portion of the capsule thickened. You can see edema around the top of it, and not shown but around the rotator cuff interval you can see edema there, and if you see those in combination you should raise the possibility of frozen shoulder. Now, systemic conditions can occur in the shoulder joint, and this is a case of probable rheumatoid arthritis, and it's got some fairly classic appearances. It's read the textbooks, so to speak. So this is our bare area, this juxta-articular position. So we've got the articular cartilage here, which is the hard surface, and then in these inflammatory arthritis cases, it tends to occur the softer bone. You've got fairly good going erosion here, and the bursa is massively distended, isn't it? So if we have a look on our coronal oblique sequence, you can see that the supraspinatus tendon is completely torn. You've got superior migration of the humeral head, and this bursa is just very heterogeneous. Okay. If we have a look at our coronal oblique or slightly oblique sequence, you can see that the bursa is massive, really, really distended, heterogeneous, and you have all these erosions up here. So in this case, it was referred for a query rotator cuff tear, and we asked them to be seen by the rheumatologist because we felt that was the most likely diagnosis. Like in all musculoskeletal MRI, we should be assessing the marrow, and we do that best by looking at the T1 sequences. Fatty marrow should be nice and bright, and then we're worried about low signal changes which are darker than the corresponding muscle, like we can see here. So this is a pathological looking proximal humerus with low signal changes throughout a cortical defect within the inferior aspect of the humeral head, and these are darker than the corresponding muscles. So we're worried that this is a pathological lesion such as metastasis, myeloma or lymphoma. Other things we should be looking out for are enchondromas, which are chondroid lesions. Really nice paper by the Birmingham group talks about a pragmatic approach to these, and I really found it useful in simplifying and understanding and assessing these and how frequently we should be following them up. And like all chondroid lesions, they're high signal on T2 weighted sequences. And then osteonecrosis, previously known as AVN, is another thing which can occur in the proximal humerus. People on steroids, like those with SLE or Crohn's, this is an area it can occur along with the humeral heads, and you can see a double line sign on those T2 weighted sequences, and it usually occurs at this 10 o'clock to 2 o'clock position. A couple of special mentions with our routine shoulder MRIs. One would be paralabral cysts. Now they're likened to the parameniscal cysts of the knee, and it essentially means that there is a labral tear. Sometimes they can be one-way valves, and if you were to do an arthrogram, they don't always fill with gadolinium, and you usually have to do more T2 weighted sequences to see them. If you see them, you should assess where they go, because sometimes they can press on nerves such as the suprascapular nerve. So they can be important if they do, and we have to aspirate them or send for a shoulder surgeon. The Geyser sign is something which likes coming up in exams, and it does pop up in clinical medicine from time to time with people with rotator cuff arthropathy. So they've got a complete supraspinatus tear, superior migration of the humeral head, which forces fluid from the glenohumeral joint through the AC joint to make this big periarticular cyst. They can be really big, like they are in this case, and ultrasound can be pretty useful at assessing that there's no internal flow or not anything to worry about, but MRI can give us more of an idea of what it could potentially be. I hope you found that useful. We've talked about a couple of things, including imaging planes, protocols, and assessment of certain structures. I'd encourage you all to really have a good go at reporting some of these, get your anatomy textbooks out, and thank you for listening.
Thank you, Dai, for that excellent presentation and sharing your tips and tricks for navigating shoulder MRI. Dai is back at Radiopedia 2022 on day 2, and this time we will be tackling MRI of the wrist. So if you're interested, we would love to see you there. We are counting down the weeks until Radiopedia 2022. Again, it is the 25th to the 29th of July. Registration is still open, so please head over to radiopedia.org to sign up if you're interested, if you haven't already. Thanks so much for joining us, and we'll see you for the final live stream in 2 weeks. Take care.